Thank you very much, Dr. Slaughter. So you heard him. He promotes the right neurovar and go to surgical implantation. But let's hear the other side. So Dr. Donker is coming from Holland. And Dr. Donker is the chair of cardiovascular respiratory physiology in the Faculty of Science and Technology at the University of Twente. Medical staff member, cardiac intensivist at the University Medical Center of Utrecht. He will talk to us about the right ventricular failure of the percutaneous use. Dr. Donker, thank you and welcome. Please.
Thank you very much for the kind introduction, and thanks a lot for the invitation. It's a real honor to be here. Thanks to the organizers and to Marvin especially. So I don't know if Dr. Slaughter already surrendered, if you have that impression, but I think before I show you the data, there's one important remark that I would like to make, and that is that if you look to the literature, you will see that it is cardiothoracic surgeons that publish on percutaneous devices. I find that the most convincing issue, actually. And there's another thing, that is that world-renowned editors of journals that are very well known to all of us foster that. And they are also cardiothoracic surgeons. So thank you very much. But let me show you some data. These are my disclosures. It's no personal fees, just research at the University of Twente. This is probably one of the first papers, peripheral VA as a bridge in right ventricular failure after LVAD. That is an experience from Germany, from Frankfurt, many years ago, 10, 15 years ago. It was clear right from the start that there is a very delicate balance between the LVAD and the ECMO circuit. And that is probably the reason that they show a very detailed weaning protocol. So balancing these two devices is very critical when it comes to VA ECMO. And they did good, 80% survival, but they faced the inherent complications that we all are very well aware of. This case report from Stockholm and Sweden, Karolinska, shows you again that a reduced flow, 2 liters of ECMO, might be wise. And this patient did very well also. Virtually all, I think, world-renowned centers have experience with VA ECMO in LVAD patients with RV failure. This is the Paris experience, the early experience. Again, this paper shows you, and this is 7 years later in Vienna, that a reduced support of ECMO is probably very important. 32 patient, large experience. Fem subclavian, reasonable survival after 1 year, and please remember, VA ECMO means 3-4 weeks in the ICU and a week on support, and you face the well-known complications. So this is a head-to-head comparison, again from Paris, VA ECMO, peripherally cannulated versus VP, the classical surgical approach. And what you see here in the context of the HeartMate 2 experience in Paris, 10 versus 8 patients, you face serious complications. This is aortic root thrombosis, and the thromboembolic events are the reason that it seems that the surgical approach is probably to be favored. So again, a week on support and 3-4 weeks in the ICU. But thromboembolic events are very important. And you see here also that in first instance, the patients are weaned, and then what is called the ECMO gap occurs, and finally, the mortality is considerable, I would say. So this is a summary of peripheral VA ECMO in this indication. So widespread international experience. It's percutaneous, it's straightforward. So at the bedside, you can cannulate, wean, and decannulate. The costs are limited, but the data are also limited. So it's retrospective. It's, I would say, biased outcome. The ICU management is really challenging, and you face complications. So what do we do in Utrecht, in the Netherlands? Well, you should know that John Calvin is still around in Utrecht, in the Netherlands. It's about proportionality, it's about costs, and that led us many years ago when we faced patients with this problem that we went for Roberto's technique that he's elaborated in this paper. So it's a bit unlike the surgical approach. So you cannulate the pulmonary artery, and you might choose for a mini RFAD or an oxy RFAD configuration. And This is the patient. It's a bit messy with a lot of catheters and wires, and you might think, well, this one Gans catheter is the right position. No, it's not in the right position. It is a challenging case with a diaphragmatic hernia and RV failure after an LVAD exchange. It was an elective exchange, and we ended up like this. I can tell you, it can be done. It's tricky and it's risky. So the experience has been summarized by Roberto LaRusso recently, comes up with 12 papers and concludes that percutaneous VA ECMO is still out there. It has been used, it is still used, but of course, despite of all possible configurations and modalities, it has drawbacks, complications, and there are new cannulas out there, and I'll come to that in a minute, and of course we need more data to be convinced. This is the Impella family, the Impella RP out there since 2015. This is a summary of the experience, well, prospective data, retrospective data, but all not randomized in trials, but single and multi-center, about 5 years experience with 100 patients reported, and the known complications of hemolysis, pump displacement, and exercise bleeding that we also know from other Impella approaches. PROTECT Duo has recently been reported systematically in 2 systematic reviews, as you can see here, so that is interesting. They both come up with 7 studies, a bit different selection. So 80 patients, 5 years experience, retrospective single center. It's mainly from Germany and the US. And of course, complications all over, but note this, there is a long duration of support. That is very possible in the PROTECT Duo if you manage this in the proper way. So mortality is variable. There are some studies reporting really excellent outcome, but I think the variability and also the dismal outcome is inherent to the population, as we all appreciate. But I think it's an optimistic view on the situation. You should note that there is superior caval vein occlusion and syndrome. This is the solution for that probably, but the other systematic review by Mark Maybauer reports also on 7 studies, a bit different selection, but comes up with a similar conclusion. So PROTECT Duo is a versatile device. It provides also respiratory support if needed, and you can mobilize the patient. The literature is limited, as we all know, so hypothesis generating probably, but we need more prospective data. Although the notion is that temporary percutaneous devices will prevail probably in the end. This is the head-to-head comparison from another systematic review, group in New York, 2019, reported the ultimate comparison between percutaneous devices, a very limited number of patients, PROTECT Duo and Impella in one group versus surgical. So you can see here in this limited experience, it seems that the percutaneous approach should be favored. What else is important is to note that the percutaneous devices are potent. This is about the reduction of inotropes after initiation of mechanical right-sided support, percutaneous versus surgical. We all know that choice of inotropes is folklore, at least in the Netherlands, probably also in the US, but it can be lowered. Whatever you choose, you do a good job. So, what do we do in practice in Utrecht? I told you, John Calvin is around still. There is some folklore in every center, but if the patient enters the ICU, we would tend to virtually not go back to the OR. That is done in Utrecht, in the Netherlands, but that is also done in New York. This is an experience from a few years ago, and you can see here a comparison of simultaneous surgical in blue, delayed surgical. That was what Mark referred to just a minute ago in orange, and delayed percutaneous in gray. So you see that when you have a good indication on the OR, you might go for surgical, otherwise you go for percutaneous. And there is another thing, then in this modern era, I don't think we would still go for one size fits all in a surgical device. We would go for an individualized approach. For an individualized approach, and certainly from my perspective as a critical care physician, you need to go for percutaneous. Thank you very much.
Thank you very much, Dr. Donker. So this was a great introduction, pro and con. So let's see what our panel thinks. But I'll go first to Dr. Slaughter and ask him, What about the longer term device on the RVAD? I mean, instead of doing the CentriMac, why don't we go just to a permanent device?
Yeah. So the our always hesitation and concern is that if they don't recover, is you've committed them to 2 devices, increased anticoagulation, 4 sets of batteries, and if they're not transplant eligible, it's not a reasonable quality of life. And so in theory, they should recover if you selected the patient appropriately, and if they're not going to, quote, recover, then they should have had a total artificial heart or a heart transplant to start with. So the idea is in patients it would be, quote, historical destination therapy. If they don't have an RV that is going to recover, giving them dual, durable, what really are LVADs, I don't think is a reasonable option.
Thank you. Why don't we go to the panel? What kind of, what do you guys do? Let's just start with from the beginning.
So, Monty Donishman. So I used to do, I've waxed and waned in my practice. When I first started, I was doing a lot of percutaneous because I thought it was exciting. I've actually come more to Dr. Slaughter's camp, where I think, you're in the OR, you might as well just, leave the OR not on insane rocket fuel doses of inotropes. And so oftentimes I will just go ahead and put an RVAD in. I'll sew a graft on the PA, tunnel it out, femoral venous, so that you can percutaneously remove it later. And I do surgical RVAD. Hybrid RVAD, let's say, because it's percutaneous and surgical.
Right.
So it's really interesting. I think you have to group the patients, as was suggested, to aim the therapy for them. So number one, there are patients who have high-risk features pre-op going in for chronic RV failure that are clearly going to need longer-term support, and however you accomplish that, traditionally done with some surgical application at that time, number one. Number two, the patients who had an operative course that was insulting to the RV, that potentially have reasonable RV function, and you need short-term support. So that's a different circumstance. And then the patients who really have, for the people that you have later RV failure or prophylactic, so they need less support. And then you have to address the mechanism. So VA ECMO is phenomenal. It pulls blood away from the heart and it decongests the body and allows the RV to function at a lesser preload, which is a different recovery mechanism than if you actually put a PERC RVAD in, whichever one you use, which allows the blood path to continue. So if you have a mitral prosthesis, you have something else, you're feeding your LVAD and you don't get root thrombosis because you have both ejection and you're keeping the blood path intact. So one is aiding a forward blood path, the other is decongesting, taking away, and generally speaking, you get more decongestion with VA ECMO per unit of flow than you get with percutaneous RVADs. And then if you're really big and you have a chronically big RV, you really have to go with surgical because that's the only way you get the amount of flow that you need to keep the patient resuscitated and get recovery. Because if you don't get decongestion and decompression, the RV will not recover.
Yeah, and just real quickly, we have some questions in the audience, but I'd like you to also, I think, started to allude to it. It makes me very nervous when people claim that VA ECMO is their standard approach. Because as you suggested, one is it increases afterload, so it diminishes the LVAD's ability to pump efficiently. Number two is it takes away actually the amount you can flow. So you actually can't run the ECMO at the sort of speed you would like to truly decompress the right side.
Very hard to balance.
Right, it's very hard to balance, and you run the risk of ultimately pump thrombosis on the left side. And I think people forget this. And once again, if they came in on it, fine, maybe for 24, 36 hours. But as a first-line therapy, it makes me very nervous when people claim, oh, I use VA ECMO. But it's my personal bias.
In that scenario, I will always, to prevent anything bad happening, I put deliberately a very small femoral arterial cannula for the VA ECMO. So I'll do a 14 or a 16 French cannula so that people can't flow more.
Yeah.
While I'm sleeping.
Dr. Feldman.
That was an excellent talk, but the elephant in the room is when you're comparing percutaneous versus a surgical approach, can the panel or Dr. Slaughter, can you comment on which one you think is better for weaning? Now, since that's a loaded question, hearing y'all's perspective on, how you would decide that your ventricle had recovered, that would be, I think, interesting.
Well, I'll go first. I know Dr. Donker, we have to get him back up real quickly. I'm sorry, we're going to have to move on. So personally, number one is they have to have a swan in place, right, before you ever get in trouble. I still find it easier to actually wean a surgically placed LVAD because you have more direct unloading, and I can, quote, reload the right atrium and right ventricle, I believe, more consistently, because the percutaneous cannulas are very dependent upon the position, right, of the, particularly the inflow, right, to the pump. And if you're a little high, you're a little low, the answer is as you start turning it down, it sort of differentially will reload either the right atrium or right ventricle. I think it's easier to sort of wean a surgically placed RVAD.
Thank you very much.
Yeah, I think we have to move on. I'm sorry, Ali. Hopefully we'll get back to you maybe at the end.